However, you have folks in New York, our centers in New York, you have 1 year to prepare to give us 80 degrees outside. Weather like this, you cannot go to the beach, you cannot take a walk, you take a run. Anything short of that, we'll have to come back to Miami. So New York.
Global warming.
Global warming? Yeah, all right, so I haven't seen global warming, I think that happened. Well, we're just going to get a sense on, clinic, infrastructure. What is diabetes care like in, University of Miami, pediatric and adult? I'll start with you, please, Dr. Sanchez.
So we have about 500 patients, mostly type 1. We have about 50 to 60% pump use. We try to have most of our patients on sensors. We're probably about 80 to 90% sensor use now. We are we are the University of Miami, so we are private, but we work at Jackson Memorial Hospital, which is the largest hospital actually in the US, and it's a large public hospital. So we see patients both private and public. We see everybody all together in one clinic. So it doesn't matter if you're funded or unfunded, and we see people from all over the county, but also all over South Florida. And a lot of patients coming from the Caribbean, South America, Central America. So we have quite a wide network of patients coming in. And so because we have such a variation of patient types and social economic, we try to make sure that everybody's on the same page with that.
Thank you. How about you?
Well, the adult service service several locations. Most of our care for the adult population happens at the medical campus that you will visit today. The medical campus is also home to the Diabetes Research Institute, which is the building you will do today, which is a leading institution in type 1 diabetes research. And we'll have the director, Dr. Camilo Ricordi, who pioneered adult transplantation, to give an overview about the structure. So the DRI, the way we call it, provides most of care in the outpatient settings for the adult population. We then provide a inpatient service in 2 hospitals, the University of Miami Hospital and the Jackson Memorial Hospital. When we are on service, we cover basically shift of 2 weeks, and it's a lot of back and forth because we cover both hospitals. We provide also outpatient service in 2 other locations, still on the campus. One is again the Jackson Memorial Hospital, and then another one is the VA. We are kind of spread around medical campus. We were having a slide supposed to give an overview how DC works, and it can seem complex at first, but once you are in the system, it's actually quite simple. Besides what is the medical campus, we also have satellite location. We have one that is in South Miami, where it's actually the main campus. The University of Miami recently opened what is called Lennar Comprehensive Medical Center, and there we provide, there is a multi-specialty center, and we provide again for adult patient diabetes type 1 and type 2 outpatient care. And then we have 2 satellite locations that are north of Miami, like 30, 40 miles. And in that case, we have some providers that are just dedicated to care in those places. We see about, we have in the past fiscal year, we calculated we have about 1,200 established patients with type 1 diabetes, and about 3,500 with type 2 diabetes. We have about 400 insulin pump users, and a rate of new onset patients that are about 20-30 per year.
University of Miami also has a very large transplant program, both pediatric and adults. It's one of the largest transplant programs. So we do, both of us see a lot of transplant diabetes also.
That's actually a good segue to my next question. So transplant program, and actually that we see a lot of international patients. So what else is unique about sort of diabetes care in University of Miami, peds, adults? And that's not a trick question, I'm just curious.
I mean, let's say when we come to transplant and transplant in general, the Jackson Memorial Hospital is the largest transplant center in the country. and is the only place in South Florida, actually Florida, that is performing any kind of transplant. Then when it comes to other transplantation and pancreas transplantation, well, the DRI is one of the leaders in the area of other transplantation. And again, Dr. Ricordi is the person who discovered and this machine for the isolation of the pancreatic islet. So we are really at the forefront of research and implementation for other transplantation. And we have also a very robust program of simultaneous pancreatic transplantation. Actually, you're going to have a lecture tomorrow by Dr. Pugliese. He's going to talk about science, but with him, Dr. Burke, who is a transplant surgeon, myself, and another colleague from now Cedar Hope, we actually pioneered first studies about the recurrence of type 1 diabetes in patients that were recipients of kidney transplant, and then developed type 1 diabetes on follow-up. So let's say we cover both fields very well.
I think one of the things that we're very strong with is actually psychology, and you're going to be hearing a lecture from Dr. Delamater later, who runs our psychology overall department head. And so we have a very close relationship with them, and we've been able to fund a lot of good studies and projects with them, and it's really helped, especially with our diverse population, to have a good team working with us for that.
That's really helpful. So, I think one of the things that science building conference like this is really to get a sense on opportunities for collaboration and opportunities to partner. So just can you sort of speak a little bit to that, what sort of opportunities do you typically partner with other centers across the country? So
we're very interested in partnering with centers across the country. We try to do a lot of joint projects between adult and pediatric. Also, we do a lot of psychology, as I mentioned, and any other group that's interested. We have Bascom Palmer, which is the #1 ophthalmology program in the country. And so we've done a number of projects with them and our population as well. But we're certainly interested in collaborating with other groups here, because I think it's so helpful. Well, we've learned so much just to be part of the project, working with other people with it.
There's collaboration in the country to the beach.
Yeah, sure.
I can't see the recurrent interest of yours.
It is, Miami, that the beach, I have to enjoy Miami.
You can swim from anywhere, so that was.
How about you, Francesco? It's also in collaboration. What are you interested in for the other adult colleagues to collaborate? So the kind is listening, from our friend from Barbados Adult Center. He likes to collaborate too. So what do you want to do with him and all this?
So in terms of area of interest, so one of course is quality improvement project we're doing, and expanding and building on what we're doing. Lately we have, or I have an interest in let's say remote connectivity, telemedicine, with the Joyce T1D, who is associating something. Okay. We are working on a manuscript thank also for the support of the T1D exchange, and it's a very interesting area that I'm interested further expanding. Then another specific interest that I have is about testing new therapies for type 1 diabetes. This is the more basic science. I closely work with a collaborator at the DRI. We are NIH funded for studies about testing a new drug for type 1 diabetes. Very basic. As of now, we are preclinical stages, so we are basically working with mice. And results are very promising. Is a drug called dimethyl fumarate. It's used in patients with multiple sclerosis, and we have very encouraging results. So those are basically now my main area of interest.
That's helpful. So one collaboration, two getting a sense of your clinic. But I think the other piece that comes up a lot in this conversation is really having a sense of what sort of struggle, what sort of challenges you have, caring for patients with diabetes in your clinic. And so we're curious on that for two reasons. One, it validates some of the other struggles people are, yes, I'm not the only one. They are having struggles, I'm having struggles too. So I don't feel like
But then two, I think we also asked that question because other colleagues here might have insights, perspective, things that work for them, so they can also share the answers. So what are some of the biggest challenges?
For us, because we have such a diverse population and we have a number of immigrants and some are here legally and don't have any funding at all. And so that's what we are doing is how to get supplies for them. We can waive our time, but we get supplies, to get laboratory testing, so that's where we spend a lot of time trying to just find ways to take care of these children. And then the other group is the ones that you're just trying to get through without, see, I said, the difficult home situation. And so one of our projects that we're working on, we call Aim for 7, and is trying to take those patients with the high A1Cs and see what we can do to get them down. So I'd love to have other people join us in that project as well. Any other suggestions people have, in terms of working with these patients?
Yeah, for us, I would say, because of the pandemic, well, we went through major challenges, like I guess all of you. Again, when we have these collaborative calls, it's always interesting because you understand and you realize that many times you share the same problematics. Well, we had a very big staff turnover, that was actually a major issue, not only for let's say staff, but including providers, and so that was I would say a major challenge. Again, and with the pandemic and major changes in both of the personnel, it comes also impossible. I mean, the difficulty of giving like 4 hours of fun every single amount of time. That is, we need to be really practical, and maybe some of your standards is experiencing something that very similar. And those are, let's say, very practical aspects. It remains also the issue that with even more expensive technologies and more sophisticated tools, time and allocated for visits is not always enough, especially when it comes to an adult clinic where type 1 does not represent the most of your patients.
Thank you. And I want to take one Pete's question and one adult question. So, question for our hosts from anyone. One Pete's, one adult. And I know your names. Ask the question, I'll make you ask the question. Choose one. All right, Nana. Nana, so tell us who you are and then ask the question.
So I'm Dr. Jones, pediatric nurse at Children's Hospital. So I'm actually interested more about the need to we talk about collaboration. And I think we all have our various diabetes populations that we like to serve, especially those with increased social determinants of health. And being as diverse as your population is, tell me a little bit about the key components of the 8-7. And then my second part of the question is, how do you kind of handle the interpreter services? Do you have diabetes educators who are bilingual? Do you have providers who are bilingual? How do you deliver that education to patients who don't primarily speak English?
Okay, so I'll start with the second one first. So fortunately, we do have both providers and staff that are bilingual. So in terms of our Hispanic population, we're pretty good with that. We have a number of people who do speak Spanish. Miami also has a large Haitian Creole population, and we don't have many providers. We don't have many providers. We do have some nurses that speak Creole. We have a large video translator service that we use for any other language besides Spanish and Creole. There's a large Russian population there, so there are some other nationalities that we use a video translation for. We do find it makes a big difference though when you can speak that language and you're not using an interpreter. So I think that helps a lot with our Spanish population. In terms of the aim to 7, we're going to be focusing on, it's actually one of our fellows today, that's one of our projects. And just a lot of intense time with the patients and trying to, where they're meeting with our educators monthly, with fellows following up with the sensor usage and if they're on a pump or using an in-pen and trying to track and making sure that we're tracking them and calling them frequently. And then trying to figure out what are the barriers? Do they need to meet with psychology? So we have psychology meeting done frequently as well. Is it a social issue in terms of funding? Do we need to get you supplies somehow? Is that how the process? But I feel like sometimes we're still even when we're doing all that, that's still not enough. There's definitely some components that we're missing that we'd like to, I was doing suggestions for.
If I can add something when you wonder about the non-English speaker population, one characteristic that is unique on Miami is that the non-English speakers are normal. Okay, so Miami is actually what is called a majority city. So more than 50% of the population are non-white Hispanic. So if you are on the city and you like something in the grocery store, you find yourself in a situation where actually everybody speaks to you in Spanish and there is no English.
I like to talk about federal projects. You have a federal and I think it's a big deal for us to be in Facebook. The support feature and one of the fellows is not there. So Andrew, what's your question?
We'll come back to you then. Right, Derek. I'm going to give us a question. I'll just say hi. Hi. You guys decide to say right here. Let's wait to see this. He's actually trying to. Yeah. Before and we are very inspiring. What I found to be inspiring and the way you should everywhere is the Davis educator together. It was the class called last Davis, I don't know if it's what happened. But what I found to be inspiring is how we get to have social work organization and a CDC in the same place. Like that, I think it is. So, what did you do?
Yeah, good question. I believe that the biggest indicator nutritionist when it comes to quality improvement they play an essential role. And I say as part of the team, although most of them are the nutritionists. And this team is based on what I call my own definition, that is a fluid team, where we have core individuals, okay, that are mostly the indicator and nutritionist, and then you have some other figures, then come and go, depending by projects and that's the academic year and so on. We try to have some links and very informal, try not to be too rigid in the structure, meaning it's a very friendly environment. And again, we try to meet with some regularity, see what are the challenges, and work on a project that are of interest for everybody. And then, when there is an interest, you're more likely to succeed.
Well, folks, can we give it up for our two hosts, Janine? And you're going to be around, your team are going to be around today, so please say hi to them and say thank you to them as well.